Welcome, everyone, and thank you for joining us for the Regulatory Ethics, Knowledge, and Support 2022 Summer Series for Clinical Trials. Our webinar today will be on the topic of enhancing research ethics, equity, and protections for uninsured and underinsured study participants, and the speaker today will be Dr. Sarah Vitone. And before we begin, I'd like to point out a few housekeeping rules. Please submit questions for the speaker using the Q&A function at the bottom of the screen. If you don't want your username shown, you may submit anonymously. Members of our REKS module will be joining us at the end for the Q&A section. And also, please use the chat function to request for technical support. So Dr. Sarah Vitone is an associate professor and bioethicist at Georgetown University and has provided research ethics consultation and is a research participant advocate with the Georgetown Howard University Center for Clinical and Translational Sciences, also known as GHUCCTS, for the past 10 years. She will present today the group effort of the faculty in the Regulatory Ethics, Knowledge, and Support module. Please welcome Dr. Sarah Vitone.
Thanks so much, Claudia. I'm going to share my screen and we'll get started. All right. So this particular project has been the much work from the group of us at REKS. And so I want to recognize the folks that I work with, Dr. Paskalev and Dr. Otato from Howard University, Priscilla Adler, Claudia Gunwin, who you've just met, and Dr. Blackman from the VA, and then myself from Georgetown University. So one of the things that is interesting in research ethics is sometimes it takes a case to get us thinking and open the door for us to work on a project. So I'd like to invite Ms. Megan Presley, who brought this case forward, and she is going to share the details of a case that has really been impactful to all of us, especially since the time of COVID. Now, Ms. Presley is going to change some of the details in the case to protect those that were really involved, but it won't impact the story of how this was brought forward. I want to say and introduce Ms. Presley to you. She serves as a project manager at Howard University's Center of Infectious Disease Management and Research Clinic. She manages the Ryan White HIV/AIDS program, Part A, and special projects of the National Significance Sexually Transmitted Infection Program. Also the COVID-19 variant immunologic landscape trial, and she specializes in quality assurance and enjoys providing necessary insight on healthcare improvements to ensure patients are provided with quality service. She has prior experience in customer service, which has offered her rich opportunities for leadership, personal growth, and passion to make a difference. Megan, we're so pleased to have you today, so I'm going to turn it over to you to describe our case.
Good afternoon, everyone. Today I'll be speaking about the case that invoked the guidance of the presentation topic discussed today. It'll be particularly about two participants that were enrolled in a trial that were uninsured, both experiencing adverse events very early during the trial period, whom had challenges accessing the healthcare system to improve their health due to, unfortunately, a lack of health insurance. I'll be identifying the participants by participant 1 and participant 2. Participant 1, I unfortunately experienced continuous headaches very, very early in the trial period. Our principal investigator assessed the participant in person, also over the phone and Zoom. And we also had a lead recruiter that served as an interpreter, connecting the participant to some community partners around the DMV area, helping the participant to enroll in some programs that serves uninsured residents with low income. Once enrolled, the participant was able to follow up with a doctor, so getting care with the doctor and follow up, and that physician did identify that the symptoms were not related to the vaccine, rather it was associated with seasonal allergies. Unfortunately, the participant did continue to experience frequent headaches, not resolving. So the principal investigator did make the decision to unblind the participant very early in the trial, within about 2 months of the participant being enrolled, due to concerns about persistent adverse effects, and also to determine which study drug the participant received. Now, on to participant 2. Very similarly, the participant did experience adverse events. Actually, a few days after being vaccinated, the participant reported very constant sharp pain that radiated down the back of his leg to his knee. The principal investigator did assess this participant also over the phone and in person, particularly in person for a physical examination, and to perform different procedures to determine if the participant was able to ambulate. The participant was prescribed medication to ease the ache and pain, and our lead recruiter, also interpreter, also worked very closely with this participant to establish care outside of the outside of where the research was performed, with our community-based, with some community-based clinics. The principal investigator did also provide a referral for physical therapy due to the participant's lack of insurance. The hospital was not able to admit the participant, informing the trial team that he was not able to register unless he paid an out-of-pocket. The participant originally did not want to attend the physical therapy due to fear of being in more pain and not wanting to miss work. So, it was recommended for them to, still proceed, and eventually the participant did recommended to various community clinics, in which they attempted to schedule appointments, never receiving calls back, unfortunately. Due to that, the participant did take it upon himself to receive an unprescribed shot from a pharmacy. And once doing that, the principal investigator did make the decision to unblind the participant, having concern that the participant would still have severe back pain, and then as well as due to the unprescribed injectable use. Both participant 1 and 2 stated feeling discarded, despite being explained to both participants from our study team that the principal investigator made that decision to unblind due to safety concerns, simply due to safety concerns. This did result in the discussion that there needed to be a standard operation procedure describing clinical trial site requirements for the management of medical care needs for uninsured study participants. This, of course, include influencing the development of an SOP that takes action concerning the healthcare needs of our study participants lacking insurance and invoking the guidance of this presentation topic today. Thank you.
I just want to give some space to just the powerful way that you talked about this and how the participants felt discarded. I think that can't go unnoticed. We have to really embrace their impression of what happened, and this is important, and I appreciate you sharing this with us because it matters to what happens next. All right, thank you so much, Megan. I hope you can stay for a few minutes for the presentation in case there are additional questions. I really appreciate the time that you put into this study, as well as spending some time with us today. Thank you so much. When we think about equity in research, our team specifically thinks about how to promoting the equity and using anti-bias and anti-racism across all aspects of the research process. And in this particular case, we are talking about taking that very explicitly and purposefully addressing the problems that were faced by these participants and calling it out and looking at the systems and the policies and what's in place. We have to shift, right, our research culture to be more proactive. And this really, from myself and Dr. Hurtado is on the call as a research participant advocate, this is what we do. We call it out, we bring it forward, we continue to press, looking for some resolution and addressing the issue. So in trying to move our research culture here at GHUCCTS across Georgetown, Howard, the VA, looking towards more proactive, right, robust planning in individual research teams with their participants, really seeking out diversity, equity, and inclusion. It's not just phrases, but with actual meaning. We considered the ethical obligations, right, that we have as researchers. The interesting sort of comparison here between what is research and what is healthcare medicine is not so separated, right? We can't have better health, better medicine without clinical research. And so it goes hands in hand that addressing the medical needs of and underinsured participants as a matter of respect for persons and social justice in both clinical trials and in medicine. Secondarily, we have to protect and advocate for diverse participants because they are essential to the rigor of the science and to satisfy ethical principles of respect, reciprocity, and solidarity. Now, I want to pause for a moment and talk about reciprocity, because this, to me, is one of the more powerful statements that we make in research. If I am asking you, a participant, to take the risk to be in the study so that we can collect data and know whether this particular therapy has the potential to help others down the road, knowing that this treatment may have no impact on you as the person. That kind of risk, that kind of participation has to be met with a relationship from the research team to protect. This is like, I'm asking you to run into the fire. I'm going to protect you the best I can in the fire. And we saw this reciprocity. Another sort of example of this reciprocity is what happened during the pandemic with the doctors and the nurses and the healthcare, right, in the hospital. So we saw reciprocity where we're asking the doctors and nurses to risk themselves we're going to give them masks and gowns and ways to protect themselves. Just in that same way, reciprocity needs to be on the research side. So we need to say that we are protecting the participants just in that same way, asking them to risk so that we can gain information to help in healthcare. And thirdly, we have serious obligations to protect, especially the most vulnerable research participants, for any undue influence or coercion that might happen as we are recruiting, especially in recruitment, right, and the time of the study. Uninsured and underinsured participants are vulnerable, and we have to consider some additional challenges. Knowing that the equitable access to healthcare is a problem for those particular participants. And in addition to that, there's another issue around that we have to consider, which is after the trial is over, how will they have access to medical care? And if the treatment that they are being part of, right, the data that they're helping us collect becomes available, will they even be able to access it? So that's a big piece of what we're thinking about related to un and underinsured. Secondarily, those folks that have limited access to healthcare, and especially primary care, have fragile health. And so we need to think about that as being a potential risk factor when they are volunteering to be part of a study, that their health itself may be an additional risk factor. But overall, our main point of action in this particular project was to make sure that there is access to standard of care while the participant is in the study. And that would have, I think, addressed the issues that these participants had that Megan mentioned. So what did we do? So our team looked at the regulatory and ethics scholarships. We looked at what had been published. We looked at research around protections and duty to care for research participants in vulnerable groups. We considered arguments around the nature and the scope of ancillary care, which is that medical standard of care, and what are the obligations of researchers. If I'm the researcher, does it matter to me, right, that I make sure that these folks are getting, my research participants are getting primary care? And we're suggesting that yes, it does matter. And you as a researcher and a research team need to consider that. We also did a review of the applicable local and federal and international regulations and practices. And again, considering the duty to care for clinical and clinical trial research participants and potential participants from those groups. Excuse me. Informed consent is always there and is a main part of our protection with all research participants. And so primary investigators and institutional review boards should anticipate those ancillary care, the medical care responsibilities that might come up. And so the participants should be informed of the resources and assistance that they may need during the study, and how that's to be specified is something that we need to think about for informed consent process and paperwork and the things that we do during recruitment. The GHUCCTS team, our team, expanded and created a demographic form to provide more information to study teams related to insurance status for prospective participants. So during the screening process, we could help identify folks that might need an extra touch point, those folks that might need extra connection to medical resources for them to be in the study. So we looked at our community medical resources, and the study team is certainly going to assess the information that's provided by the participants, but our group, the REKS group, the Regulatory Ethics Knowledge and Support Group, will serve as the primary facilitator of resource sharing. And we have a medical resources document that I'm going to show at the end of my slides. I'll unshare my screen so you can see what that looks like. Claudia, who you met earlier, worked and created this form, and it's going to be something that's fairly valuable. Claudia, do you want to put the link in the chat? Now, those of you who want to make sure you have access to it, you can certainly get it in the link, and we're going to put it up on our website. But having it will be very important to research teams. And certainly the folks in the community engagement module who are interacting with research teams will consult with the study team to make sure that these resources are well known. The Institutional Review Board already looks at vulnerabilities due to influence and coercion, medical care inequities, but they need to consider additional vulnerabilities of these underinsured participants. And as they're reviewing protocols, they may need to ask the question, how are teams anticipating ancillary care responsibilities that might arise, and how are they, again, providing those touch points for the participants? The primary investigator has to be making relationships with community providers and the community engagement module, and ensure that all members of the team are trained in the procedures for, again, adding this layer to inform consent and assessing the medical needs of uninsured participants. Study coordinators need to be able to answer questions related to this. And as Megan mentioned, the unblinding or unmasking or withdrawal of a participant for their protection, how that is expressed and how we can help participants to understand when it's necessary and what that means in a more respectful way, and to address issues that participants have, related to that. And maintaining touch points. This is a really important part of what study coordinators do, and having consistent contact, with the participants during the trial. Again, our community engagement folks are going to be consulting with resources and helping study teams as well. I want to say a few words about research participant advocates. There's about, right now, there's somewhere in the ballpark of about 60 research participant advocates identified in the United States. They work out of different research hubs in the CTA program, and they act as an independent advocate for research teams, and they are available to promote and protect the interests of vulnerable participants. We can be called on to help with difficult consents if there are issues that the study team is just unclear about how or what kinds of vulnerabilities they're discovering, and how to help continue to move the research forward, as well as to protect the participants. Even when there are risks, we can make it safe. The advocate acts as an unbiased observer, and sometimes, again, has a voice in a different way that can help, again, bring these out, these issues around vulnerabilities that are so important to give space to. So in conclusion, we think that including diverse participants in clinical and translational research ensures that the data is of the necessary quality to be generalizable, to improve the health for all, and diverse participants add to our mission for social justice, which is necessary, again, for the better health for all. Also, adopting an inclusive approach to the medical needs of vulnerable and underinsured participants is necessary. Planning for this in the protocol, the budget, providing information on community resources, all the touch points that I've already mentioned, following up with support, and all of this documented in the research records is very, very important. We have some references, and I'm happy to provide that. I'm going to take you now to show you the resources that I mentioned. This is the document. Let me scroll to the top. It's available in the link that you have in your chat, but it's the preventative healthcare resources in the DC area, DC, Maryland area. And so it's quite a long list. I think it was, what was it, 29 pages? It's quite a bit with all the links. It talks about address, phone number, where the medical clinics are that you can help your research participants have access to. And oh no, it's what is that, 23 pages. So I just want you all to be able to see that. Now it looks like I'm going to unshare my screen if we want to open up to the panel, and we can look at if there are any questions. Thanks for putting that in the chat, Claudia.
Of course. And so in the Q&A section, we have one question. It says, I'm interested in the assertion that patients felt discarded. Can you please say more about this?
Yeah, I appreciate the question too. Megan?
How I interpreted the participants mentioning that they felt discarded was they simply felt disposed. They felt casted out. They felt like their safety wasn't prioritized, especially considering that the adverse events that they were experiencing were non-related to the trial vaccine. So that's how I interpreted that.
Are others, I'd be interested in how others can type, perhaps you can type it into the QA, have experienced that and how to address it with research participants. It's possible to that these safety issues need to be handled better. I mean, participants may not understand, right, the significant risk that we're concerned about and need to feel supported. And so I am very concerned about how that is perceived to a participant who has volunteered to be part of something that's so important. Yeah, so feel free to type that into the chat. I'd like to welcome Dr. Atato, Dr. Blackman to come on screen to comment on our project and other things that have heard. Good morning, Dr. Blackman.
Good morning, Sarah. That was an excellent presentation. And Megan, thank you so much for sharing with us the important experiences that you've described. I think, as has been emphasized by Dr. Vittone's really excellent presentation, this is a really important topic, and I think we all recognize that. In a practical sense, several issues strike me beyond those discussed. Clearly, all of us on this call and our many colleagues are interested in promoting health equity, both in the care of patients as well as in the care of patients in the conduct of their participation in clinical research, which is today's topic. And we have miles to go before we sleep to do it better. So one issue is, of course, the recognition in institutions, not just among individuals, of the importance of making uninsured and underinsured people another target for improvement in health equity, in addition to other underrepresented populations. So we talk a lot about underrepresented populations, people of color, people with disabilities, people who are older, children, all of whom are, relatively speaking, underrepresented in patient-oriented research. And of course, there is a lot of emphasis in all of those target groups. People who do not, in this country at least, people who do not speak English as their native language, yet another target group. And I think one of the target groups that has been under considered generally is the group we're talking about today. Uninsured and underinsured people, many of whom are people of color, many of whom, as was the case today, do not have English as their native language, and combine, many different facets. And what I'm really saying is, not only do we need to educate each other, which in efforts like today's, but we need to have our institutional leaderships embrace, health equity in all of its dimensions for all categories of people, including the category of person we're talking about today. So that's one issue that strikes me. A second issue that strikes me, and probably I would guess everybody on this webinar, is the practical aspect of budgetary concerns. Because a lot of times, a concern is, how are we going to actually pay for this? Megan commented upon not accepting one of the particular patients unless that patient had insurance. Many of us, I would imagine most of us, are used to conceptually saying, well, we don't care whether people do or don't have money. That's not the basis of our treatment. The basis of our treatment is somebody in need, period. But the reality is it has to be paid for. And so, for example, grant-giving bodies like the NIH or the Department of Defense or the Veterans Administration Research Arm, et cetera, don't always provide funds for this sort of thing. And institutional settings has to pay its bills. So we need to figure out a way, not on this meeting or this call, to address the budgetary constraints that are really pressing. And as Dr. Fatone emphasized, among many things she said in her excellent presentation, the informed consent process doesn't necessarily always address the finances of what will happen if and when a person has an adverse effect that is either related to the study or that occurs during the study, but is not really caused by the study, but still occurs in the context of the study. Because life happens and incidental medical things occur, as might have been the case in the people who Megan described. And so we really need to improve our informed consent process, as Dr. Fatone emphasized, both for people who are insured and people who aren't insured, to make it clear, not only are we going to protect you, but, we are in some way acknowledging and protecting you in a financial way to the best of our ability. So, those are sort of elements that strike me.
Yep. I will just say that probably one of the biggest things that I think that we have that really, I would say, sort of was confronted us was we need to stop just saying that this is a problem.
Exactly.
Have some action now. Clinical research needs to come on board with where healthcare is and needs to continue to move this forward. There should not be two standards. So how we are addressing this on the clinical research side is important, and it needs to be continued. There needs to be more action on this. We've known this was a problem. We've been concerned about it. Now we're bringing it forward, and this is going to make maybe, right, on the research side, there could be some discomfort to this, but we have to move through that.
Absolutely.
Dr.
Absolutely.
Otado, do you want to comment?
Sure. One thing I would like to add into that, when research participants come into, or when study reach out for people to participate on the clinical trials, there's usually a misconception that folks come in thinking, I'm joining this clinical trial, maybe my medical, it will also give me the medical clinic care that I need. So that's usually would be a confusion there. So it just need to be made very clear, this is clinical trial, is not a medical care. But sometimes people join clinical trials thinking that they'll also get their all their clinical problem that they might have, a care that they might need that they don't have, because maybe they don't have health insurance. So they think if I join this study, I can get some medical care that. So usually that misconception is so important. I think that studies need to usually emphasize at the beginning.
Yeah.
Well, I think that Dr. Hurtado makes a point that we were talking about together a moment ago, and that is the informed consent really needs to include exactly what Dr. Hurtado is saying. People really need to be apprised not only of the study and the study risks and the study content, which is routinely done, but of the focus upon what happens if there's an adverse effect, either more or less serious, and that requires medical care, and what the obligation is of the participant and what the obligation is of the study team and so forth. And one other aspect, and perhaps Dr. Ratona or Dr. Hurtado, you might want to comment on this, is that the team of people, the REKS team, in working together on this important issue, has drafted a guidance document that hopefully will be finally approved and be available widely for utilization, not only in our clinical translational science research program across our multiple institutions, but perhaps serve as a model for our institutions more generally for their research, patient-oriented research activities, and even hopefully on a national level when this is published in the in the medical literature, which it will be at some point, serve as a model for other consortia like ours in the CTSA program nationally, because clearly this, as Dr. Ratone said a moment ago, everybody recognizes that it's an issue and a problem. And the issue now is to address it and develop action plans to properly address it. And so one of those relates to the articulation in writing of a narrative guidance document, proposed document, that addresses many of the points that Dr. Ratone so eloquently presented today in writing, to be shared and modified as needed, of course, but to be shared both locally and ideally more widely.
Right. So thank you so much for joining me today and for those comments. I will say that our guidance document has been worked on by our group and is moving through the channels. Claudia cannot say enough about that fabulous document you have. This is really an action item that investigators and research coordinators can immediately create touch points for research participants to get connected to clinics. We are blessed in our DMV area to have such a robust opportunities for persons to have access to standard of care medical treatment. So let's make that happen. Let's spread the word. Thank you so much for coming today. I hope that you find this helpful. And as we move forward, feel free to reach out to us. And I will close our meeting now and give you some time back to have some lunch. And hopefully you will have a nice day.
One more thing, Sarah. I just wanted to mention the evaluation form.
Yeah.
So I will be sending an email with the evaluation link. Please take the time to fill that out. And in that email, I can also attach that link to the Google Docs with the resources.
Thank you so much, Claudia. All right,
Thank
everyone,
you.
have a great day.
Yes, have a great day. Thank you. Bye.